Good morning, Dr. Williams. Please mute your line if you are not speaking, but make sure it is yours and not mine, please. Mine is the FSSA line. Please don't mute me. And then as done previously, when we have to vote or do a motion, I will go through the roll call. You can vote aye, nay, or abstain through that roll call. And I think we can go ahead and get started. If you want to provide public comment and you are online, you can shoot a message in the chat box before we get to that point, and we will do public comment at that time. All right, let's go ahead and begin. Dr. Ott, remarks of the chair.
Sure, so I will go ahead and call this meeting, the September meeting, to order, and I don't have any further remarks.
Thank you.
Mr. Ross, John Ross, you're not on mute. Okay, now he's on mute. All right, perfect. All right, thanks. Any opening comments from OMPP, Ms. Lugo?
No comments, just welcome and thank you for being here.
All right, next item on the agenda is the approval of the minutes.
This Dr. Marshall moved to approve.
Dr. Class second.
I will second.
Courtney, we have
All
a
right.
motion to approve it. Oh, sorry, Amanda, a motion to approve in a second.
You're fine. So Dr. Ott,
Aye.
Dr. Klaas,
Aye.
Ms. Pippin,
Aye.
Mr. Johnson,
Aye.
Dr. Marshall,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
I just want to make sure here. Dr. Rao, did you by chance join as one of the phone numbers? All right, not hearing that, so I just didn't want to skip his vote. All right, we had all ayes, so that will carry. And then we will go on to our update then. Somebody want to give me a head nod just to make sure we're good on seeing my screen over there? Thank you, Kelly. All right, so for our PA stats for August, overall we had 71% approved, which was right around 20,600, and then 29% denied, just a little over 8,000 in those statistics. When we're looking at the manual PAs versus the silent auth PAs, in the silent auth area, we had 75% approved, 25% denied. 25% of those that were denied went to the call center, where 79% were approved and 21% were denied. And then on the manual PA side, we had 49% approved and 51% denied. So when we're looking at our overall trending graph, you can see a slight increase in August. We did have a little bit of a dip in June and July, but we do tend to see an increase in August with kids going back to school. So we have a lot more stimulant PAs, and some of the more mental health PAs occur at that time. Yes, Mr. Johnson.
Hey, Amanda, interesting information, given the 25% of the smart PAs that denied, that have denied that are reviewed, what is it that the smart PA methodology may be missing that causes a high percentage? I think like 75% of those cases reviewed are approved. Is there anything that particularly is missing in the methodology that could improve the accuracy of that smart PA?
So usually it's not anything that we can handle in our methodology. It's things like a delay in the medical claims loading. So it has to do with when the prescribers load their medical claims. So sometimes we don't see the diagnoses or see the CPT code at that time. There's other cases of things that we just can't know in the system. So if there's, let's say, a offending claim hitting, we can't know if that claim was discontinued or not. So they may tell us over the phone that other agent was in fact discontinued. So those are usually the rationale for why we end up approving more of those cases that end up going through, is we just don't have all the information in the system. And unfortunately, there's not a whole lot we can do about it given the delay or the system's ability to look at it.
Okay, so most of them I would expect then are just newly diagnosed cases.
We do have that, yes. We also have, I guess the other thing that I would say that we tend to approve a fair amount of is the antipsychotics have a metabolic monitoring rule. And if it's their first time coming through and they haven't had a metabolic monitoring yet, we give them a 3-month approval, then we give them another 1-month approval after that to try and get metabolic monitoring. So you will see approvals for that too, even though that will reject out of silent auth as well.
Good
While
enough.
they're trying to get that lab. Any other questions on that? All right, thank you very much. So when we look at our top 10 silent auth PAs, you can see the stimulants are number 1, which is no really big surprise here, and then opioids and antipsychotics, which have been in the top group there for quite some time. And then when we go into our top 10 manual PAs, we had early refills, and then mental health edits, which sometimes jump into that group, and then quantity limits. So this group does tend to move around a little bit cyclically, just depending on what's happening in that particular time period, but nothing really surprising with what we're seeing in this top 10 either.
Amanda, could I ask, the
Yep.
diabetic supplies, any idea why those always get denied or almost?
Yeah, so it's usually around the continuous glucose monitors, the CGMs is what we see the majority of the requests for. And so it's just, we have a preferred diabetic supply list. So most of the time it's for items outside of that preference or people that don't qualify for the CGM. So a lot of people, there's a lot of CGM requests is what we see the vast majority of. Mm-hmm. Any other questions? All right. So when we look at our opioid statistics, we again had an increase in August, increased about 3.91% of total utilizers, and new utilizers increased again by almost 10%. Our kiddos are staying about the same, and their day supply is 5.3, so staying about the same as well. You can see the breakdown there, and I'll go into the graphical breakdown, which I think might be helpful. But just want to point out, and we'll see it in the other graph, we do have an upwards trends in the opiates. I don't have a great explanation in my mind for this, aside from I do think, the pendulum keeps swinging. So we had the pendulum, swing one way where we were really restricted, putting a lot of restrictions on prescribers, saying to discontinue and not use these. Then the pendulum kind of swung back a little bit and said, well, maybe we were a little bit too harsh, like we have people discontinuing that shouldn't be, et cetera. So I feel like maybe we're in a little bit of that pendulum backswing. But otherwise, I don't see anything that's jumping out at me where I'm like, oh, it's because of this that we're having this increase. So it may also be to, during times of COVID, we had less surgeries, less elective surgeries. We're having more of that now, although COVID's kind of back up again. So we'll see what happens with that. But at least at this time, COVID's, a little bit down from where it was. So we may be having some of that too, of reflective of comparing to COVID times versus now. But those are kind of just thoughts on my end from what I'm seeing. I don't see anything in the data that's really pushing me to say this is why this is happening right now, but it's something that we'll continue to monitor. And certainly if anybody on the board has any, great insight as to like, I know it's because of this, I'd love to hear it as well, but that's kind of what I'm speculating at this point. So when we look at our graph of the over 90, you can see, again, the vast majority of our people are in the less than 90 MMEs. We've got some that are in the 90 to 120, and then much smaller numbers in the other groups. And then this is kind of what I was talking about in our overall trend, where you can see that upward trend that's really been happening since I would say the January, February timeframe. We start to see kind of an upward swing then at that point. Again, just a reminder, the greenish teal color at the bottom is the current utilizers over 18, the cranberry color is the new utilizers, and then the purpley blue color at top is the under 18. So not a lot of changes in the under 18, and even, an upward swing in the current utilizers, but really I think the vast majority tends to be in that new utilizer space. So we see them in the less than 90. That's where we're seeing more of those people coming on. So just something that we're continuing to monitor and watch and see if there's any other things that we can extrapolate from what's happening at this time. Mr. Johnson.
Sorry again. Hey, Amanda, with those numbers, you're reporting unique utilizers in this data. How does the total population of Medicare covered lives fit into that? Are we seeing possibly any increases in that or any changes in that would give us more of at least a normalizing of what the numbers are showing?
Did you mean
Medicare or Medicaid?
Medicaid covered lives? You mean total Medicaid lives or Medicare? You said Medicare. I just want to make sure I
I'm
understand.
sorry, I meant Medicaid. Yeah, I work in the Medicare space, so I'm sorry.
No, you're fine. So total lives overall, we're hanging fairly steady from what we've seen. It'll be interesting to see what happens here over the next several months as we're unwinding, since there are people that are losing coverage and we're in the process of unwinding. So after the COVID health emergency or the public health emergency, we're in the process of reevaluating eligibility. So it may change overall, but at this point, I would say it hasn't drastically changed or drastically gone up. I mean, definitely during COVID, we saw increases as we kept people on, but I would say now it's kind of, we're in the backwards phase of that. So this is a great example of that increase that we talked about too, happening in the less than 90 space. So you could see around that February timeframe is when we really start to see the increase in the less than 90 claims, which again kind of makes sense that our new starts have to be in that 60 or less MME, and so they fall in that lower category. So we are seeing the vast majority of the increase happen in this space, which is good versus in the higher spaces, but again, something to think about and continue to monitor. When we look at everything else, so the 90 and above, again, you can see the decreases in the higher strengths that we've had over time, and then the lower strengths are starting to increase a little bit as we move people through the space. I always caveat that this is a really hard trend for us. We have very, very small numbers, so a couple of people moving can really change the way the graph looks, and our people move in and out to managed care quite frequently. So just keep that in mind when you're looking at the graph, but overall, no real big surprises on this side from what we're seeing. Any other questions on the opiate reporting before we go into the doctor shopper?
Amanda, this is Chris again. If we were to overlap possibly things like Suboxone over the opiate utilization or Narcan type products over there, would we see any changes or any similarities in the growth we're seeing with the opiate utilization?
So not that I'm aware on the buprenorphine piece. That's been, I would say, relatively similar to what we've been. And I'm looking at the managed care because we all track the same thing. And really, it's been fairly consistent since we opened that PA up from where that utilization has been. We haven't, maybe a slight rise when they took away the XDA waiver, but not huge yet at this point. So no real big changes there. Narcan, unfortunately, our utilization continues to be, at least from what we see on the claims side, much lower than we'd like it to be. So I would say we're not necessarily seeing an increase of where we'd like Narcan to be as far as people having rescue meds available. And then, we're not, at least on my end, I'm not looking at the medical data to know the amount of rescue utilization that they're having in the ER, et cetera. So I don't know, managed care partner wise, have you guys noticed any changes in that on your end? They're all shaking their head no. So I would say from best I can tell, no, not a significant shift there. Any other questions? All right. For the doctor shopper review, I'm going to spend not nearly as much time on this since I feel like it's better to look at the graphs and easier to understand. But just a reminder, We have a Dr. Shopper edit in place. We evaluate it to make sure we don't have anybody kind of abusing that Dr. Shopper edit. And so we take kind of 60-day periods at a time, since that's what the Dr. Shopper edit runs through. And then we evaluate those and compare them against each other and see how many patients we have kind of fall in these different areas. So these are the individual 60-day time periods and the vast majority of patients fall in the less than 3 providers. And then also a reminder, when you're looking at these, providers could be in the same office group. Maybe they're seeing a PA or a NP or whoever at that point in time. So just keep that in mind. So when we look at the overall trend, again, when you're seeing the graph overall, most of them are less than 3 prescribers during that time period, just a few in the above that. And then when we compare over time, where we're comparing 2 different time periods together to see, are those people who maybe have more prescribers, do they persist over a longer period of time? And they really just don't. So in this case, we only had 1 that was in the 5 or more that persisted. In this, we had 0, and then another 0, and even no 4 unique prescribers in that group either. So from this standpoint, we don't see anything that's concerning in this group, as we usually don't see anything concerning, but just wanted to have that review with you all to know that it is still occurring and that the Dr. Shopper edit appears to be doing what it should be doing, and we don't have any problem with that. Any questions or comments there before we move on? All right, I am going to turn it over to Ann Kuhn. She is going to present the start of our health equity retro DUR, and then I will pick it up after she goes through her few slides. So turn it over to you.
Thank you. Good morning. My name is Ann Kuhn. I'm one of the pharmacists with the Office of Medicaid Policy and Planning, and I just wanted to provide some background for today's retro DUR and newsletter topic proposals. The Centers for Medicare and Medicaid Services created 6 pillars to align with their strategic plan to help drive and promote program goals. One of these strategic pillars is to advance health equity by addressing disparities within the healthcare system. Next, thank you. So we decided to incorporate CMS's Advancing Equity pillar into our IHCP pharmacy benefit goals. So in order to do this, we needed to first identify a health disparity within the benefit, develop and implement an initiative, and then track the impact. So we decided to start with the previously identified healthcare disparity and then determine if it existed within the pharmacy benefit. So that brings us to the Medication for Opioid Use Disorder Equity Initiative. Regarding the opioid epidemic, we know that many lives have been lost. The CDC reported almost 80,000 opioid-involved deaths in 2022. We know that medications for opioid use disorder or medication-assisted therapies are associated with reduced mortality in people who have an opioid use disorder diagnosis, and also that these therapies should be individualized with patients remaining on therapy as long as needed. So we also know that health disparities related to MOUD have been identified. So there was a CMS study looking at Medicare fee-for-service enrollees with an opioid use disorder diagnosis that illustrated that Black or African American and Hispanic enrollees were less likely to utilize MOUD when compared to non-Hispanic white enrollees. A study of Medicaid claims showed lower odds of both buprenorphine and Vivitrol receipt among African American, American Indian, Alaska Native, Asian, Hawaiian Pacific Islander, and Hispanic members compared to non-Hispanic white members. And then there was even an Indiana Medicaid claims study that found that men and white enrollees with an opioid use disorder diagnosis were more likely to receive OUD services compared to women and non-white enrollees. So this information was taken from the Kaiser Family Foundation State Health Facts page and illustrates opioid overdose age-adjusted death rates per 100,000 members of each population in 2021. So you can see that opioid overdose death rates in Indiana were greater than those of the United States overall. And additionally, that our African American or Black population experienced an exceeding number of opioid overdose deaths in 2021 compared to the other reported races. So this slide has a breakdown of the 2021 IHCP members with an opioid use disorder diagnosis by race per 100,000 members of each population. So this includes all IHCP members, so both MCE and fee-for-service. And you can see that the data is inconsistent with what you would expect after seeing the previous slide related to the opioid overdose deaths. So the CMS study previously mentioned reviewed data in kind of an interesting way, where they looked at the percent breakdown of members with an OUD diagnosis and then compared that to the breakdown of enrollees utilizing MOUD to determine if the utilizing group was over or underrepresented. So here we have IHCP data from 2021. We had close to 74% of our IHCP population with an opioid use disorder diagnosis utilizing MOUD therapy. And just to note, these are point of sale claims, so they include the buprenorphine products and Vivitrol. So CMS's data found that non-Hispanic, white, or Caucasian enrollees were overrepresented. And while the American Indian, Alaska Native enrollees had equal representation, all other race groups were underrepresented. So our data showed that, oh, sorry, I'm still previous slide.
You're fine. I'm sorry.
That our non-Hispanic, white, or Caucasian, and Asian and Pacific Islander groups were overrepresented, and then our American Indian or Alaska Native and non-Hispanic, Black, or African American groups were underrepresented. And then looking specifically at buprenorphine utilization, as that makes up the majority of our utilized MOUD therapy. In 2021, when compared to the number of Caucasian or white members with an OUD diagnosis utilizing buprenorphine therapy, our Hispanic population had around 10% less member utilization. Our American Indian, Alaska Native population had approximately 15% less member utilization, and our African American or Black population had more than 20% less unique member utilization. And then again, looking at 2021 buprenorphine claims data, the average number of claims per member utilizing buprenorphine for our African American or Black and Hispanic members was 32% and 38% less compared to the average number of claims for Caucasian or white buprenorphine utilizing member. So the pharmacy benefit has done a lot to kind of open up the access to these therapies for the treatment of opioid use disorder. Our preferred products are available without prior authorization. We don't have limits on the length of therapy. We don't require dose reductions. We want to ensure that all IHCP members with an opioid use disorder diagnosis are able to benefit from the therapies. So we have some health equity improvement to do there. So we'd like to include information on health disparities related to MOUD in our DUR newsletter, but we also want to provide some targeted outreach to prescribers in areas where an OUD diagnosis is most prevalent among our African American, American Indian, Alaska Native, and Hispanic IHCP members. So here we have heat maps of these targeted areas by race, in which the teal or more green color represents counties with a greater OUD diagnosis prevalence. So hoping that this additional education and outreach increases MOUD utilization to improve the lives of our diverse IHCP member population.
Thanks, Ann.
Yeah.
Any questions before we move into the rural properties, which might help show how we're gonna move forward with this?
Hi, this is Chris. I was looking at those particular counties too. What impact does access, because a lot of those are in very rural areas where just access to providers in general are very difficult to achieve?
So we did notice that when we were originally pulling the rural properties, we thought, or at least I thought in my head, well, let's pull people who prescribe MAT in these counties, right? So we can target those. Turns out there's none. So that in itself is a problem. But there are a fair amount of physicians in the counties that we've targeted. So I think I counted yesterday, it's 171 or 172 physicians that we're going to target in this first round in these counties. There's some other counties that we're including in not just the darkest, but the next kind of dark level. that we decided to include kind of PCP providers at this point. Like, okay, if there's nobody really prescribing MAT, let's try and go after PCP, as well as anybody who might be doing, you know, psychiatry, MAT, just kind of those people that we think would do it. Because obviously I don't want to send a letter to a urologist or something like that. They're not going to prescribe MAT, or very unlikely to prescribe MAT. So that's what we decided to target, and kind of found that 171, 172 prescribers, with the idea that we can hopefully educate and, you know, let them know there's a problem, number one, and there's a problem in their county, and hopefully encourage, you know, especially now that the XDEA is not a requirement, encourage some of these prescribers to be engaged and help to get some of these members. So we can talk a little bit about what we want to do with that, but I want to make sure I get to Dr. Ott too before I do that. Does that help answer your question, Chris?
Yeah. I mean, I also suspect that some of those groups are busy enough where they're at in these particular counties, and they just have a tendency to want to avoid substance abuse disorder members because they're busy enough with the issues they already have in their counties.
So Amanda, this is Beth. Sorry, Dr. Ott. Leslie confirmed for me through a little head nod. This includes the MCE data as well.
It does.
I do think it's important when we started talking about doing this, and I apologize if you guys discussed it while I was on PTO. I know, like our BH team, we have a lot of things in flight, and we have things in flight in rural counties as well. So as we're doing this letter reach out and we're doing this, I think we have to come back together with our BH teams to talk about what is already being done and how that's already being measured. And then if there's any consistent learnings or any gold standard that we can share amongst each other. So I didn't know, would you guys be able to provide at some point in time our MCE data that rolled into this separately? Since you did an aggregate, can we, or did you send that and I just haven't gotten caught up yet?
I can pull that through the cube easily, sure.
Okay, I think that would be good.
Just of note that when we talk about this for the letters, we're not sending patient-specific letters. So we're just doing a general education, like, please be aware. And then more along the lines of, if you're having a barrier because of transportation or income, whatever the case may be, giving them the resources and the tools to help figure out those barriers with their patients. So that's what the letter is really going to focus on. We don't plan on sending them a list of members or anything like that, because obviously that wouldn't necessarily apply, but just kind of getting them more aware and potentially more likely to prescribe to somebody at that point.
And I think one of the things we struggle with, of course, is consent for that discussion. So there's a lot of things that the MCEs have to work on when it comes to, and I'm not a HEDIS expert, but it's actually that connection between the PCP and the mental health provider, and that consent of sharing that information back and forth that also gets in the way. So that's another piece, but I think it's a great project you guys are bringing up for health disparity especially.
Dr. Ott.
Hi. So yeah, I really appreciate this, and I'm excited to work on this health equity space. I think there are a couple things. One, my first question is this, you mentioned primary care providers, but is it just physicians, or is it going to go to nurse practitioners and physician assistants?
We included all.
Okay.
In the.
Okay. So the other thing that I'm thinking about is, and to what Beth said, I think there's one of the things to think about as we see what the response rate is to this and moving forward, is that it can be a primary care thing. It doesn't have to be a mental health provider, doesn't have to be involved initially, or even down the road. It kind of depends on the person. And so I think there's a lot of stigma and a lot of educational needs that perhaps as we move forward, there are some partnerships that Indiana Medicaid could partner with that I may be able to help facilitate, like the Indiana Rural Health, those kinds of things to think about with this. So I think this is great. Thanks.
Thank you. And Dr. Williams, I see your hand as well.
Yes, thank you. I agree with Dr. Ott. This is great information. My concern is this is going out to prescribers, but is this information also going out to the pharmacies? I would hate for prescribers to have an uptick in prescribing, then they get to the pharmacy and, oh, we're out of stock. It won't be in for another 3 days. So then now we're creating another hurdle.
That's a great point. So I do think that is something that we should look at and sending out to the pharmacies that are in these counties to let them know that we have this initiative around this disparity and sending that out to the counties. I think that's a really good point. Yes, Dr. Hott.
Sorry, I have to do this again. Just jumping off of Kelly, because Kelly and I have known each other for so long that we can do this so well. I think the other thing, so bring up the pharmacy aspect, is the over-the-counter naloxone. And I have some concerns about some of the rollouts and what some of the, at least chain pharmacies, are doing with it in considering keeping it behind the counter when it's literally one of the safest things we have available. And so if we could think about how to message the community pharmacies, that would be great in conjunction with this. I think that would go a long way to improving access also.
Yes, and so you're jumping my gun a little bit in that we have a newsletter topic, so our newsletter topic, of course, is about the health equity, but also about naloxone rescue. We decided to pair them together because I think that's a great time to bring the two of them up. So, but that is a great point. Any other questions before we look at the actual rural properties here, or we can look at the rural properties?
I have a question, sorry, I might have missed this. Are emergency department physicians also included in the targeting for prescribing?
So I have not yet. And the reason being is because a lot of those end up getting sent to the hospital and then kind of lost, and I wasn't sure where to go with that. That's not to say, so I get right that the emergency physicians are often kind of the first line, and it would be great to educate them as well. So I'm not opposed to doing it. I just know that in some cases, those tend to kind of get shuffled around and lost. So at this point in that 171, 172, they were not, but I'm not opposed to adding them and attempting it to see where we get.
The other piece you could do, possibly, Amanda, is each hospital system's quality department. I know that the MCE's teams also work with quality contacts. So that may be a way to communicate into that quality team, to communicate out to the EDs, about the initiative, more of a coordinated, because I agree with you, the letters just going in there, sometimes they're locums and they're from out of state too, so.
Mm-hmm. Yeah, I do think maybe some level of hospital conversation, because the hospitalists are there too, potentially rounding on somebody. So yeah, I do think they're kind of the first line there in some degree. So what we were looking at here is, when we pulled this data, we were looking at members, 18 years of age and older, both genders. And then we kind of already discussed, so the prescriber letter is going to target the race discrepancy. That's kind of the whole point in the initiative, and targeting, those things we talked about to try and help really engage members, educate the prescribers about doing it, and letting them know that in their county, this is especially discrepant, so that hopefully that will make them more aware that there's even more of a problem here in their county. So again, we mentioned targeting primary care physicians, but we can certainly look at hospitalists and ER doctors as well in the high impact zip codes. So we've listed all of those out there. They're in the main counties on this heat map that we talked about earlier. Definitely all of the darkest teal, and then in the African American Black heat map, kind of this next level down, you see like these kind of darker-ish teals. We're covering those. And then what we have is we have a second list, actually I should go back to this, of kind of even the next level down from these darkest ones going into kind of the third less darkest, however you want to look at it, where if we get through this set of letters, then we can kind of pull prescribers in those counties and then send out another set at that point if we want to send out another set to those prescribers in those counties. So we kind of have a two group there. Yes, Dr. Ott.
I left my hand up because I just don't want to forget what I was going to say, which is quite possible with me these days. So it might also be useful at some point as this rolls out and as you think about how to expand some of this to better target is to partner with the Indiana Academy of Family Physicians. And the current president is a provider that I work with. So if you are interested in that at some point, just let me know. Maybe that connection might help too.
So something that we're also looking at, which I think this might be very helpful for our newsletter in general, we've talked about it a little bit internally, is I have another state right now that we wrote a newsletter that we're getting accredited for free CE, that we had a department that we were able to do that with, or we're in the process of doing that. This is a newsletter that I would equally like to do that for in Indiana for free CE, just so then maybe we're not just getting doctors in these counties, but doctors everywhere to do it and do the CE and recognize that. So hopefully that would equally be helpful if we can push it out and say, here's free CE, come read it and do it and have that information. So that's kind of a secondary goal to try and get that pushed through as we move forward, but that's something we're talking about internally as well, which I think would be really helpful for some of those groups. All right. So again, our patients were looking at diagnosis of opioid use disorder without MOUD. We don't have negating diagnoses or therapy. And then our outcome is going to be, we're going to be looking at MOUD treatment in previously non-initiated patients. So we're going to look at all patients, right? Not just those that may have been discrepant, but we want to see, is there a rise in all patients? Is there a rise in the target populations? What are we seeing, kind of across the board? So that is something that we will pull in all of the patients after that time period to see what kind of headway we're able to make. And then I mentioned our newsletter topics already, so it'll be the medication for opioid use disorder in Indiana Medicaid members, the health equity initiative, and then for naloxone, the availability, prescribing, and monitoring of naloxone for rescue. So certainly we'll be talking about the OTC formulation in there as well, and trying to increase our use of naloxone and having that availability for patients as well. Any questions or comments on the DUR initiative or the newsletter topics? Oh, I should mention, originally we had on the agenda that we were bringing the Dear Doctor letter today. We chose to hold off on that because there's going to be so many things between the newsletter and the Dear Doctor letter that really need to work hand in hand with all the different programs we include in the newsletter versus the Dear Doctor letter, since it's going to be a little different than we normally do. And it will be a manual mailing, so we're not going to list patients out and things like that. It's just going to have kind of the information. So we wanted to bring the two together. It'll be, I think, easier for us to write the two together as well as you to review the two together at the same time. So that's why we chose to hold off and bring it next month.
Hi, Amanda. I do have a question. What information is going out to the members regarding this information?
So we don't send, typically on the fee-for-service end, send any member mailings, but I know managed care often does send member mailings. So I don't know, do you all have any initiatives in place today that are going out to members that you're aware of?
To address this issue, or?
Yeah,
I
just think it'd be a great idea for the members to know. I mean, information is power. So they may go in and say, you know what, I want to see what my doctor can do to help me with this diagnosis that I carry.
Yeah, they're conferring, and so I would say maybe it's something we take back and think about maybe best way to approach that.
Yeah, Kelly, I think we have to kind of almost form a work group because we have so many things in flight across the different MCEs, both from a member and a provider perspective, to see how it all ties back together so we can make it the most successful as possible.
Yeah, and Beth had mentioned earlier, it has to be a cooperative effort because it involves our other departments such as care management and behavioral health. And, yeah, quality, all that, so.
Yeah, I think it'll be really good for members to know that we are looking at this and we do realize there is a disparity and we want to address it.
Any other questions or comments? I'm excited that you are all excited. We're excited for it. So it's excitement all around. If I could have a motion and a second then to approve the retro DUR and the newsletter topics, and then we'll be back next month with the newsletter and the Dear Doctor letter.
So moved. Pat?
Seconded.
Mandy, do you need me for anything other than to say we have a motion and a second?
That's all I need you for. So Dr. Ott.
Aye.
I mean, not all I need you for. I need you for
Okay,
a lot
fine.
of
I heard you say that. I'm gonna hold you to it.
Dr. Klass.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Aye.
Dr. Marshall.
Aye.
Dr. Rao.
Aye.
Thank you. Dr. Simon.
She left.
Oh,
Aye. I'm here
she's
on the Zoom now.
on the phone. Okay. You snuck out so quickly. I didn't even see you leave. Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
Thank you very much. We did have a follow-up that we wanted to bring to you on our retro DUR analysis around the, you might remember we did a COVID-19 vaccine second dose. So we went after those that got their first dose and then tried to encourage the second dose for them. And so this is our follow-up analysis. We did we were reviewing claims from December 15th, 2020 through January 31st, 2022. We had 2,235 members that were determined to be eligible. That was after we reviewed CHIRP data to send out the letter. So one of the things I want to point out is we have not had the opportunity to review CHIRP data yet. We're working on getting that. So as of right now, we only had 111 members that got the second dose. Unfortunately, I don't expect CHIRP data to really move that needle a whole lot. I wish I could say it will, but given how it moved the needle before when we first reviewed, I don't anticipate it really moving the needle a whole lot now, which is why we decided to still present it to you all. If we are still planning on reviewing the CHIRP data, so if we get that and all of a sudden astronomically the numbers change drastically, we will let you know. Otherwise, we'll just kind of incorporate that CHIRP data and put it in the CMS DUR annual report because I'm not expecting it to change drastically. So a little disheartening here, but maybe not super surprising. The pharmacy benefit expenditure increased by $4,130.31, and that's just due to the admin fees that we pay the pharmacists for administering the vaccine. Any questions or comments on that? I know not super great. All right. That is all I have for this first part. We will come back in new business, but any updates from managed care today? I know we don't have slides, but anything that you all needed to provide? Isn't that wonderful? I'm getting a lot of no's, so I will say no's there. Any new drugs today that we need to talk about? Seeing none. Any liaisons with other boards? I know I had some public comment in the chat, but let's see too. We're checking the room. And let me see if I can get my fun little timer going here. So I have that for you all. No public comment in the room. All right, so it looks like we have none in the room. So it looks like we have one online from Miriam with Sarepta.
Yes, I will go ahead. Good morning. Thank you for the time. My name is Miriam Albustani. I work in medical affairs at Sarepta. Today, I will address the committee regarding delandistrogene moxeparvovec, known commercially as Elevidys, for the treatment of Duchenne, a degenerative neuromuscular disease caused by diverse mutations in the dystrophin gene. Elevidys is an AAV gene therapy indicated for the treatment of ambulatory patients 4 through 5 years with Duchenne with a confirmed mutation in the DMD gene. This indication is approved under accelerated approval based on expression of Elevidys microdystrophin in skeletal muscle. Continued approval for this indication may be contingent upon verification of clinical benefit in a confirmatory trial. Our confirmatory trial in 126 patients is fully enrolled. Last time I addressed the committee, I highlighted the clinical trial information in the FDA label. Today, I would like to address the topic of discussion during the last DUR, which is corticosteroid used as part of Elevidys treatment. Reading from the FDA label, to reduce the risk associated with an immune response, corticosteroids should be administered starting 1 day prior to Elevidys infusion. Initiate a corticosteroid regimen following the appropriate schedule per table 1 of the label. This regimen is recommended for a minimum of 60 days after the infusion, unless earlier tapering is clinically indicated. I refer the committee to the USPI for a complete overview of safety information, including adverse events, monitoring, warnings, and precautions. In summary, Elevidys is an FDA-approved treatment that targets the underlying cause of Duchenne in ambulatory patients aged 4 through 5. We respectfully request the committee cover Elevidys through FDA prescribing information. Thank you for your time. I'm happy to address any questions.
Mr. Johnson, did you have a question for Miriam, or are you raising your hand for something else unrelated?
I guess my question kind of relates to Elevidys, because I know that we tabled the criteria for review last month. Just trying to check the status of that criteria.
We do have it for new business today with the update around that. So we've got that there. Any other questions for her today? All right. Thank you. And it looks like Stacy's giving time back, so I don't see any other public comment. If you were unable to send a message in the chat box, if you want to raise your hand or just start speaking, we can do that as well. Stacy, we are presenting debut in new business, so wasn't sure if you still would still like to speak, or if you want to give your time back officially.
Yes, please. If it's being discussed, I would like to comment, please. Thank you.
Okay, sure. Go ahead and start whenever you're ready.
Okay, thank you. Good morning. My name is Stacy Rapatsky, and I'm an HEOR director at Acadia Pharmaceuticals. Debut, or trofinetide, is the first and only FDA-approved treatment for Rett syndrome in adults and pediatric patients 2 years and older, and we request access for patients without inappropriate restrictions for the following reasons. The efficacy of trofinetide was established in a 12-week phase 3 placebo-controlled trial in female patients 5 to 20 years of age with Rett. Rett patients treated with trofinetide achieved a statistically significant difference in favor of trofinetide as compared to placebo in both co-primary endpoints as measured by the RSBQ total score that assesses a range of symptoms, and the clinical global impression improvement score that evaluates how much the patient has improved or worsened. The most common adverse reactions were diarrhea and vomiting. The label includes warnings and precautions related to diarrhea and weight loss. Healthcare professionals are advised to inform patients to stop taking laxatives before starting trofinetide, and an interruption, reduction in the dosage, or discontinuation of trofinetide is required if severe diarrhea occurs. More details are included in the label for prescribers to consider when prescribing trofinetide. In closing, Debut is the first and only therapy approved by the FDA for the treatment of Rett syndrome in patients 2 years of age and older, with demonstrated efficacy to help improve signs and symptoms of Rett syndrome versus placebo at 12 weeks. I respectfully request that Indiana Medicaid allow access to Debut so that appropriate patients with Rett syndrome can obtain this FDA-approved treatment that may help to address unmet medical needs for these patients. Thank you for your time.
Thank you. Any questions for Stacy today? All right. Thank you, Stacy. And let me just make sure no other public comment today. And hearing and seeing none. So let's go on then to old business. Any old business for anybody today? All right. Any other new business before I get into mine from the board? Okay, we've got a few things to cover today in new business, so I'll try and be as brief as I can. The first thing that we have is updating criteria in our antiviral monoclonal antibodies criteria for Synagis. And this is for the less than 24 months of age to include the following: that the prescriber has submitted valid medical justification for the use of Synagis over Beyfortus. So for those of you that know that Beyfortus is now available and part of the VFC program, even though it's not a vaccine, so that's fun. And then the member has not received Beyfortus already within the same RSV season. And then if there's a lack of Beyfortus, we'll certainly consider that as a medical justifiable reason for the season. And then by JUVEC, we are clarifying some of the criteria, that the member continues to have open wounds secondary to DEB, and the member is receiving clinical benefit as demonstrated by closure of previously treated wounds, and then incomplete wound closure will be assessed on a case-by-case basis. So just updating a couple of criteria points there. And then for DEBUT, so this is a new drug, new criteria for Rett syndrome that we just heard about. So for initial authorization, they have to be 2 years of age and older and weigh 9 kilograms or more and have the diagnosis of Rett syndrome with both of the following. So there's a genetic analysis for mutation as well as a diagnosis of typical or classical Rett syndrome with a period of regression followed by recovery or stabilization confirmed by all of the following. So then they have partial or complete loss of acquired purposeful hand skills, loss of acquired spoken language, or impaired or absence of ability to walk. And then hand wringing, squeezing, clapping, tapping, mouthing, and watching rubbing that seems habitual or uncontrollable. This would be prescribed by or in consultation with a neurologist or specialist with the expertise in the management. And then the prescriber attests that the member doesn't have any of the following, so brain injury or moderate to severe renal impairment. And then you can see the requested dosing there, which is 120 mLs per day or 8 bottles per 30 days. And then reauthorization, history of the requested agent for at least 90 of the past 120. And then prescriber submitted clinical documentation demonstrating that they have achieved some disease stability or clinically significant improvement, or that they have not experienced any additional decline or more rapid decline than what they would have expected. And then continuing to attest that the member doesn't have any of those contraindications, and again, the same dosing. All right, miscellaneous cardiac agents. We're clarifying for Corlenor, clarifying the initial authorization and reauthorization criteria for heart failure to have the members 18 years of age or older, and then updating the reauthorization for inappropriate sinus tachycardia to have members 18 years of age or older, and history of Corlenor for 90 of the past 120 as confirmed by claims history or chart documentation. And then some updates on our preferred brand list. So Duexis is being removed from the list as the brand was discontinued. Dymista is being removed as it is now back ordered. And Spiriva HandiHaler we are adding to the list. And then Vyvanse, the caps and the chewables, we're adding the brand as preferred to the list. If there are any issues with out of stock or something along those lines, then obviously we would assess the generic for any of those at those given times. All right, so we already discussed that we were bringing this back, and so we did make an update to the PA criteria. So this is medical benefit only, again, just as that FYI. So still looking at members 4 years of age and older and less than 6 years of age, the diagnosis of Duchenne with confirmed mutation of the DMD gene. They don't have a deletion in exon 8 or exon 9 as confirmed by genetic testing. And then we've got the antibody titers. They don't have prior gene therapy. And then the prescriber is attesting to monitoring or assessing lab values post-infusion, and will continue to monitor post-infusion. So they'll assess prior and post. And then member is infection-free and does not have uncontrolled acute liver disease. And then here's the piece that we are bringing back, which is the member will be prescribed an oral corticosteroid regimen prior to initiation of therapy, but we're not specifying at what prior that is. And then will be continued on therapy for at least 60 days unless there's some other tapering that's indicated at that time. This will just be assessed by a prescriber attestation through that. Any questions on that update? All right, hearing none, I now have a lot of vaccine updates around VFC, which are non-VFC pharmacies and VFC, both. So this is for the non-VFC pharmacies. So you can see the COVID vaccines that are being added there with a limit of age 19 years and older, and then the coverage for all the current COVID-19 vaccines are being removed. So we expect to see this very similar to maybe like the flu shot, where we're adding new ones each year and taking away. So that's kind of what we're doing here. For smallpox vaccine, adding an age limit of 18 years of age and older and a quantity limit of 1 dose per 3 years. Smallpox and monkeypox vaccine, 18 and older, and a limit of 1 dose per 28 days, 2 doses per 2 years. Tick-borne encephalitis, an age limit of 1 year through 15 years, and then ages 1 to 3, it's 1 dose per 30 days, 3 doses per lifetime. 4 to 15 is 1 dose per 30 days, 4 doses per lifetime. And then tick-borne encephalitis vaccine, that's the higher strength, the 2.4 micrograms, we're updating the age limit to 16 years of age and older. Now we're into the VFC pharmacies. So these are the pharmacies that would be dispensing VFC only. So we've got the younger age groups here. So you'll see the COVID vaccines with their age limits of either 6 months through 11 or 12 years and older. And again, removing the coverage of all the current COVID vaccines for those. And then some other VFC vaccines. So the dengue virus, adding an age limit of 9 years through 16 years and its dosing limit. Smallpox, adding an age limit of 18 and older and its dosing limit. Same thing for monkeypox. The tick-borne encephalitis, the lower dose, age limit of 1 through 15 years with the doses listed there, and then the higher dose, the 16 years and older for the VFC. That is all the vaccines. There was a lot. Any questions on any of those? Or anything that I just covered in new business? If I could get a motion in a second then to approve new business, I would appreciate it.
Amanda, one question on the Elevatus, the criteria. I noticed that it was explicit to oral corticosteroid therapy. Is that, not to be nitpicking, but is it just sufficient for corticosteroid therapy regimen instead of specifically identifying a particular route of administration?
That's a good question. I think their package insert specifies oral prescribing information.
It is for 60 days. I mean, you don't want to get a daily injection. No.
I mean, it would be highly unlikely for somebody to get a daily injection of corticosteroids, but I don't want to say that they potentially wouldn't. Yeah, I mean, we could review that if that happens. If they happen to, for some reason, have to do injectable, but I'm not sure what that reason would be.
You could change it to systemic as opposed to oral.
Yeah,
Okay.
I agree with that.
We can do that.
Yep.
So we'll do systemic corticosteroid. Okay, thank you. Any other updates or things? All right.
Dina,
Can I get a motion?
Marshall, move to approve.
Chris Johnson seconds.
So there's
All
a
right,
motion
Dr.
to
Ott.
approve in second. Aye.
Dr. Class,
Aye.
Ms. Fippen,
Aye.
Dr. Marshall.
Aye.
I skipped you, Mr. Johnson. I'll come back. Mr. Johnson.
Aye.
Dr. Rao.
Aye.
Dr. Simon. We may have lost her on the phone. Put her as abstain. Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, so we had that all approved, so that motion will carry. Thank you. Any other new business that we need to cover today that we didn't already? I am hearing none, seeing none, so that will take us to the last agenda item, Dr. Ott, for adjournment.
Okay, so I don't know, does everybody want to hang around longer or do you want the rest of your day? Okay, I move to approve. Ah, it's totally Friday. I adjourn this meeting because it seems like I need to do that too.
Thank you so much, everybody. Have a great weekend.
Have a good weekend.
Enjoy the rest of your day.
Bye.
Bye-bye.